Ladies and gentlemen, Mr. Chairman, thank you for the invitation to speak about early complications after total knee arthroplasty. And the data for this presentation are from the Swedish knee arthroplasty registry. And as we heard, perhaps we cannot do better. Like Ove said, Sweden have, at least up to now, a little bit better results than the other Nordic countries. So a little bit background about the Swedish knee arthroplasty registry. It started in 1975 and it covers today all units in Sweden performing knee arthroplasty. In Sweden, it is compulsory to report all health care to the National Board of Health and Welfare, and every citizen can be identified with a unique social security number. The healthcare data are kept in the National Patient Registry, and as compared to the patient registry, the knee registry holds information of more than 95% of all primary knee arthroplasties performed in Sweden. The number of reported patients in the knee registry has always been higher than that reported to the National Patient Registry. The knee registry collects prospectively information about primary arthroplasties and revisions from the participating units, but they are not obliged to report re-operations. So the definition of a revision, as we say it, is adding a component. If you, for example, add a patellar button, if you replace any component, even the tibial insert is considered a revision, and removing components without replacing them, for example, an amputation or an arthrodesis is also considered a revision. Re-operations are all the other kinds of procedures performed in or at knee level, not involving any of the prosthetic components, for example, a synovectomy or a closed reduction. And in this presentation, I use the word secondary surgery, and that means either a re-operation or a revision. And about the National Patient Registry, it contains information on diagnosis, procedure codes, dates, hospitals, etc. And it's possible to compare with other registries if you have an ethical approval. So, in this study, I have looked at the primary surgery performed during the 5-year period from 2002 to 2006, as identified within the knee registry. 2006 was chosen as the last year because the 2009 revisions are not fully analyzed. And these knees were then matched against any revision or re-operation performed within 2 years from primary surgery. The match was performed both within the knee registry and in the National Patient Registry. So almost 46,000 primary knee arthroplasties in 40,000 patients were identified during this time period, and almost 90% of the knees were total knees, and of them, almost further 90% were without a patellar component. 10% were uni knees, and we also have a small proportion of femopatellar prosthesis. Of these 46,000 knees, 4.6% were identified with one or more secondary procedures within 2 years from primary surgery. 1,000 of these secondary procedures were identified within the knee registry, and a further 1,600 procedures were identified in the National Patients Registry with no corresponding record in the knee registry. Knee prosthesis surgery in Sweden is more common among women than men, and comparing the demographic data between the groups, there were relatively less women in the group having secondary surgery than in the primary group. And And the patient with secondary surgery were also significantly younger than the primary group. So the typical patient with risk for secondary surgery would be a relatively younger man. More than 80% of the knees who required secondary surgery had only one further operation, either a revision or a reoperation. Knees with more than one secondary procedure were in more than 95% of the cases infected knees. In this slide, a knee is only represented once, regardless of how many procedures were performed. And as you can see, the frequency for secondary procedures is unchanged during the 5-year period. So you can say that your patient, you can say that in Sweden that slightly less than 5% of all patients require secondary surgery within the first 2 years. And this is just to show you the frequency of secondary procedures per participating unit. So each of these, each of these bars represent a unit or a hospital performing knee arthroplasty. And it's a couple of hospitals with no frequency of reoperations. But when you look at this, of course, the case mix factor is of importance if you want to really analyze if there is a difference between hospitals. And I can tell you at the bottom here is the university hospitals in Sweden. And up here are more high-volume centers performing arthroplasty in relatively healthy individuals, which you might expect. Here you see the yearly frequency of either one revision or one reoperation within the first 2 years of primary surgery. The frequency is unchanged during the 5-year period, and about 2% of the knees each year are subject to a revision, and about 3% is subject to a reoperation. So what are the causes for these secondary surgery? These causes were identified from both registries, both the knee registry and the patient registry, and smaller groups were put together, showing bars. Common causes for secondary surgery were infection, patellar problems, joint stiffness. The patella group includes all problems concerning patella. So, for example, a dislocating patella is presented in this group. In the trauma, it includes fractures, dislocations, tendon or ligament ruptures. Here on the y-axis here you have the relative distribution, on the x-axis the different causes. And as you can see, infection is the dominating cause for secondary surgery, accounting for more than 1/3 of the total number of procedures. Reoperation for infection is slightly more common than revision for infection. Concerning stiffness, this seldom involves revision, but is the single most common reoperation performed. And together with infection, they alone make up for almost 60% of the secondary surgery. The patellar revisions are almost exclusively adding a patella component, and the small number of patella reoperations are performed mainly due to a dislocating patella. And as you might expect, you see therefore causes like loosening and instability. Revision dominates, whereas trauma and wound problems usually have reoperations. And to put everything in perspective, you can see the actual frequency for each cause. It's very low. and about 0.5% of the knees are revised because of an infection. And what is interesting is that more than 1% of all knees experience stiffness of such a magnitude that it needs further procedures. And the most common reoperation for stiffness is mobilizing the knee under anesthesia. If you look at men and women separately, you have the same dominating causes for revision. And in women, you have patellar problems as the most common cause for revision, followed by infection, loosening, and instability. And these accounts for more than 85% of causes. In the men, infection alone accounts for 45% of the cases, followed by patellar problems, loosening, and instability, also 85% of the revisions. And looking at uni knee versus total knees, the revision causes are totally different. As for the men and women, infection, patellar problems, instability, and loosening is dominating with more than 90% of the revision in the total knees, whereas in the uni knees, instability is the most common cause for revision, followed by progress of disease, pain, and infection, accounting for 80% of the revisions. In the others group, which is the black up here, the dominating cause for revision was what a surgeon called technical error, putting in the uni knee and when it was revised. If you look at the reoperations, men and women have the same dominating cause for reoperations. Stiffness, infection, trauma, and patellar problems accounts for 90% of causes. Infection is relatively more common for men, whereas stiffness dominates in women as cause for reoperation. And looking on the same way between total knees and uni knees for reoperation, the causes for reoperation are not that different. Stiffness, infection, trauma, and patellar problems is dominating with more than 90% of the reoperation in the total knees. And in the uni knees, pain is also a dominating factor for reoperation, and it might seem strange that stiffness is the second most common reason for reoperation. You might expect that they have a better range of motion. In this slide, you can see that almost 2/3 of the reoperations are done within the first 6 months, and reoperations are less common with time. But revisions do not show the same pattern as reoperations. Revisions are as common or rare throughout the whole 2-year period after the primary arthroplasty. The relative distributions of causes for reoperations within the first year of surgery is presented there, and within the second year on the right bar. And you can see that the relative distribution changes somewhat, but you have to bear in mind that the number of patients also decreases a lot between the first and second year. But stiffness, infection is the most common ones. And you look at the same on revision, you can see the number is quite equal, so you have about the same number of revisions between the first and second year, but the relative distribution changes between the first and second year. You have less infections the second year, and patella problems and instability increased during the second year. So in this slide you see in the left bar the type of primary arthroplasty, and in the right bar you see what kind of primary arthroplasties are represented in the group who had a reoperation or a revision. And the patellofemoral prosthesis and the stabilized prosthesis and the uniknees are overrepresented in the group with further surgery. So I guess if you have a problem with a uni or a patellofemoral prosthesis, the threshold for converting them to a total knee is low. And the patients who had primary surgery are operated with hinges or total stabilized prosthesis are probably cases that differ in many aspects from the standard patient.
1 minute.
So the mean age for the different courses at primary surgery are presented in this slide. So, and the dotted line you see here represent the average age in the knee registry for surgery, and the whole line is represented the mean age for these patients at time of surgery. And you can see the patient with trauma and infection and wound problems are slightly older than the average, and stiffness is slightly younger than the other patients. And you might wonder why. It could be that younger patients perhaps demand higher flexion and is not satisfied with the results and are more prone to further surgery on that aspect. And the patients subject to further surgery did not show an increased rate in deaths, which at least I could have expected, that the cases with revision or reoperation would have had a slightly higher rate of deaths. So what is important from a registry point is to analyze which patient we do not have any knowledge of that didn't come to our attention. And you can see that 104 revisions that should have been reported to us were not reported. That means that 92% of all revisions during this period were reported to us. So if we look into these revisions to see what causes they had, we have infection that dominates with more than half of the cases. And if we look specific into these infections, you can see that what procedures were done. 1/3 was an arthrodesis. We had changing of the tibial insert and also amputation as a major procedures. And the problems with these patients in Sweden is that they, in many cases, is not handled in the orthopedic units, but other units, and the surgeons might not consider an amputation or arthrodesis a revision, and therefore they are not reported. And also changing tibial insert, leaving the other components in place, some doesn't think it's a true revision. So to summarize, you might say that as much as 4.6% of the knee each year have one or more secondary procedures within the 2 years of primary surgery, and about 2% experience a revision. And this is perhaps surprisingly high, but as a single surgeon or a hospital, it is impossible to get a hold of these data. And we also tend to forget complications our patients have. So without a registry of this kind of data would never come forward. And infection and stiffness is accounting for more than 60% of the secondary surgery. Stiffness is usually treated with a closed procedure, but from the patient's perspective, you need in-hospital care and a major setback in the rehab. And since we only use 10% patella components. Addition is a common cause for revision and also needs hospitalization. And furthermore, we have no exact knowledge of the results of these patients. Other conditions are very rare, and further surgery due to technical mistakes is seldom reported. More than 90% of the knees in Sweden is limited to 5 brands for total knees and even less brands for uni knees. And what actions is taken? Since 2008, we try to register the type of antibiotics, the timing of antibiotics, and its relation to start of surgery, which is known from other studies that this is of importance. And in the board of the knee registry, we have decided to add information about revisions because the cause for revision is not always easy to find out and is finally determined at time of surgery depending on the surgeon's finding. And it's not always the same reason for doing a revision and what you find in the knee. And we also have in Sweden a nationwide project called PRIS, which aims to halve the frequency of infections. So I would like to thank you for your attention, and those of you who are interested in the report can find it in the exhibition hall.